Good morning, everyone, friends and colleagues of the ITI. I'm so excited to be here among so many friends and esteemed colleagues that I've been watching through the years. Today, we'll be talking about digital workflows. And on the screen, you can see more than 100 arches restored with complete digital workflows. And I'm going to take you on a short journey on the amount of time that we have. A short journey on the evolution of digital workflows. So the patient of the day will be Gary. Gary is an edentulous patient. He came to the practice with a set of complete dentures, seeking fixed rehabilitation. So what do? The first thing is we assess the existing set of dentures. It satisfied the aesthetic, functional, and phonetic requirements, so we convert it into a radiographic template. We did the dual CBCT scan technique and imported the generated DICOM files into a virtual planning software, the co-diagnostics. We did the digital implant planning for the maxilla and the mandible. The mandible, we found out that it was a knife-edge mandible. So we had to do some bone reduction simultaneously with the implant placement. How do we do that? We use the stackable guide surgery system, the smile in a box, as it is known commercially available. It includes anchor pin guides and bone reduction guides, and on top of that, we stack the implant placement guide and also a prefabricated provisional. This is how it looks when you transfer it in the patient's mouth. And after the implants are placed, we can even provide the patient with a fixed prosthesis the same day, with an immediate loading protocol, by converting the prefabricated prosthesis after picking up the temporary abutments. So we did that both for the top and the bottom. We used an FP3 type of mandibular prosthesis and an FP1 type of maxillary prosthesis. Three months passed by, and the patient comes back to assess and confirm the osseointegration. So now, after confirmation of the osseointegration, we need to move forward. We can do it with an analog workflow or with a digital workflow. The analog workflow takes about 5 visits. It starts with 2 impressions. We take an impression of the provisionals. We remove the provisionals. We take an impression of the teeth, of the implants. But how do we do it digitally? How do we implement a digital workflow? We do the same thing. We will take 2 scans. A scan of the teeth, of the provisional, and a scan of the implants with the scan bodies. So these 2 scans, when we started implementing this double digital scanning technique, or DDS, because it has a sexy name in the States, we shorten and make acronyms for everything. We implemented since 2017. Experimentally, 2018, we published the first paper, and we did a series of publications using fiducial markers to aid the data acquisition with the intraoral scanner and also merge the STL data. So fiducial markers in the maxilla, anchor pins in the mandible, leading to the fabrication of a prototype. Single visit. Life-changing for us and also the patient, shortening the visits. During COVID, we had nothing better to do, so we started publishing the results. So 61 cases we published. You can scan the QR codes for whoever wants to get free access to the articles. How many do you think out of these 61 cases done with completely digital workflow led to a passively and accurately fitting prototype? About 90%. The maxillary ones led to passive fit. The mandibular ones, no. 6 out of 19, about 1/3 did not fit. So digital workflow is great, but there are some limitations, especially in the mandible. So what do? We have to verify our workflow. And when we verify our workflow, we can do it with the analog approach by splitting copings together. By the way, thanks to an oral surgeon, Ed Bedrosian, for the slide. We can do it digitally with the iOS data, but there is also a third way. You can actually use the immediately loaded prosthesis once you confirm that this is passively fitting and the abutments are torque tested, and just backpour it. But why not do something different now? Use digital technology as a vehicle to do a digital backpour. And this gave the birth of the so-called digital backpour technique or reverse scanning technique by using those reverse scan bodies attached to a passively fitting provisional to capture the implant position extraorally and bypass all the intraoral challenges that we encountered during scanning of the edentulous mandible with the elevated floor of the mouth, saliva, lack of keratinized mucosa, the vestibules, and so on and so forth. It is commercially available as known as Revex. It is an extraoral technique, and it leads to a very precise and efficient workflow. How does it work? We will take our intraoral scanner, we will scan the opposing, we will scan the provisional, and we will scan the bite. These are dentate scans. Very easy to do and very efficient. Then we will take a second set of scans. We will remove the provisional, and we will scan the soft tissue. And then the actual provisional, we will connect those Revex scan bodies, and we will scan it extraorally, scanning always from the occlusal pattern. Those 3 STL files are handed over to the technician. The technician merges the files together and fabricates the prototype, just in one visit. Again, one visit, triple scan. Prosthesis, opposing bite, soft tissue, and prosthesis scanned extraorally to acquire the implant position. On the second visit, you try the prototype and also the verification jig that was derived from the iOS data. And on the third visit, you insert the final prosthesis, just in 3 visits. Let's go back to Gary. How did we implement this new concept for the treatment of this double arch patient? So 3 months later, the implants are integrated. If it is an analog workflow, we take impressions of the provisionals and we take impressions of the implants. But now we will do it digitally. So first we will take the dentate scan of the provisionals, as you see. Also appreciate the power of provisionalization and soft tissue conditioning, especially in the maxilla. That soft tissue 3 months later looks nicely scalloped nowadays. This is how it looks the moment we remove the provisional. And this is how the soft tissue looks like. You can even cut yourself with that papilla. So now we will take our scanner and scan the soft tissue. That's the second scan. And here comes the third scan, the most important one, capturing the implant position. But we do that extraorally, not intraorally. It is very challenging to scan the edentulous mandible, especially when there is a lot of resorption or lack of keratinized mucosa, which is quite common. How does it work? We scan from the occlusal, go buccal, lingual, and finish on the intaglio. Takes about a minute and 10 seconds. So those 3 scans, the dentate scan of the provisional, the soft tissue scan, and the extraoral Revex scan, will be emailed to your technician, merged together, and cross-articulated. Because the STL merging that we use in the digital language is pretty much the cross-articulation that we used to do with the analog workflow. What you will get back on the second visit is the prototype and the verification jig for those who are emotional and they want to verify the workflow. Obviously, if there is a misfit, you can section the jig, reconnect it, and move on to the final step. This workflow works with the tie base at this point. So you can cement your tie bases to the definitive prosthesis on a cast that was retro-engineered from the verification jig, or you can do it freehand. But the workflow, after multiple studies that we've done, but is recommended, is cement them on the retro-engineered cast from the Revex jig. This is the final prosthesis in 3 visits. But what about the evidence? What about the science about that? How predictable is this? So together with a team with Arman Bedrosian and Kostas Choklidakis, we ran a few studies where we assessed if the scan pattern has an effect, and we found out that the occlusal scan pattern is the most accurate. We assessed the material that we will use for the fabrication of the prototype, if it's going to be milled or 3D printed. That was also determined to be milled. Not that the 3D printing does not work, but it does not lead to 100% accuracy of it, as in our studies. So if you implement this new protocol and you use milling technology, you will get 100% fit of your prototype. Remember, with the previous digital workflow protocols, we had about 90. And 90 is high, but it's not 100%, which necessitates that you are careful, verify precisely before you implement the fabrication of the final prototype. We also ran a study to assess the effect of the implant number on the accuracy of the protocol. So we treated 30 arches. 15 of those included 4 implants, and 15 of those included 6 implants. This is currently in preparation. The data were clear. Whether we use a 4-implant scenario or a 6-implant scenario, implementing the reverse scanning protocol led to 100% prosthesis fit. I want to thank you for the attention. I want to thank my team, because whatever I showed you today is part of an amazing group of clinicians, minds, innovators, and in a relentless pursuit of simplifying protocols for us, the clinicians, but also for the patients. Because patients don't come to us to get implants. They don't come to us to get workflows or protocols. They come to us to get teeth. Sometimes we might forget that. So in the journey of becoming efficient, not only delivering high quality of treatment, but also simplifying the treatment, digital technology is a great vehicle. But it's just a vehicle. If you put garbage in, you will get garbage out. So to implement this protocol, you have to have a passively fitting provisional. A passively fitting provisional will lead to a successful outcome. Thank you for the attention.